Thank you very much. Yes, in fact, that was going to be my first question, was who is familiar with self-controlled methods? I know at least one of two of you may be, but...
I think one of my colleagues conducted self-controlled study with air pollution and heart disease.
Ah, yeah, okay.
But, yes.
But no, yeah, it's not a very familiar topic, I think. Okay, that's good. So the talk I'm giving assumes that you know nothing about self-controlled methods. So if you know nothing, it's for you, it's good. Okay, so we're going to start by thinking about confounding, a familiar topic, and then we'll discuss some situations where I think the conventional study designs may not work very well. And we'll talk about how two particular self-controlled methods, so the self-controlled case series and the case crossover design, we'll talk about how they work, and I'll give you some examples of each of them. We'll talk about the advantages and limitations as well. Okay. So first of all, confounding, and it's the problem that if we're doing epidemiology, it's the problem that we face in almost every study. And it's all about alternative explanations. So it happens when the association between an exposure, maybe a drug, and an outcome is mixed up somehow with some other exposure, which happens to be more common in the group of people who are taking the drug that we're interested in. So this is a familiar concept to all of you, I think. Yeah. Now, I just want us to think about when we approach a study question and we want to make comparisons and how this might be difficult for us to do. So here I've got a cartoon example where maybe we've got a doctor over here, and he has two patients. They're roughly the same age as each other. They're both women, and they both have depression, let's say. And so the doctor has to decide which antidepressant to give to each patient. Now, you can probably see that these patients are not the same as each other. So they're the same age and sex, but I think the lady at the top is more frail than the lady at the bottom, who looks considerably more healthy and fit than the lady at the top. Okay, so they're same age and sex, but otherwise they're quite different. Now let's imagine that the doctor decides to give one of them an SSRI antidepressant and decides to give the other one a tricyclic antidepressant. Now these are two different types, two different classes of antidepressant, and let's imagine that we as researchers want to know, is treatment with SSRIs compared with tricyclics, is it associated with an increased risk of hip fracture? So we know that people who take antidepressants can fall more often. Maybe they get confused or they have low blood pressure because of the antidepressant. So they're more likely to fall, and therefore they may be more likely to have a hip fracture. Okay? So that's a question for you to keep in mind. Another question that we will often have to think about is, let's imagine we have a new vaccine. And in this example, we've got 8 very young patients, young babies, and we've got a new vaccine, and we want to know whether the vaccine is associated with an adverse reaction. Well, let's imagine that the vaccine is given to, let's imagine the intention is that we give the vaccine to all children. Well, we know that in reality, there will be some children who don't get the vaccine. So here we've got 7 of these babies are given the vaccine. 1 of them, for some reason, is not given the vaccine. Now, if we want to do a study to find out if the vaccine is associated with an adverse reaction, do we really want to compare the seven children given the vaccine against the one child not given the vaccine? Now I think, and I'm not making any judgments, but I think that children who don't get vaccines are unusual or strange in some way. It could be that their parents have some massive objection to vaccines. This can happen. Or it could be that the child is maybe sick or is different to other children in some way. So if we want to do a comparison between children given the vaccine and children not given the vaccine, we may have some major difficulties. So it could be that there is no good comparator group. This would be our conventional approach. Maybe we have a cohort study of exposed and unexposed, and we just follow them up to see what happened. But I think that in instances like these, it could be that the patients in our exposed and unexposed groups are too different from each other. And it may be that we cannot measure the important differences between them well enough to be able to adjust for the confounding that this would introduce. And if we can't do this, or if nearly everybody is exposed, then I think we need a different solution. Okay, so going back to the question of antidepressants and hip fractures. So hip fractures are a big public health problem. They happen particularly to older people, and a woman who's aged 50 has a 17% lifetime risk of having a hip fracture. That's quite a high risk. For men it's a little lower, 6%. But each year, for people aged over 60, 10% of them are prescribed an antidepressant. So if we're concerned that antidepressants may lead to hip fractures, this could be a big public health problem because it's a common exposure and a common outcome. So it's a question that really matters. Historically, people had been using for many years the older tricyclic antidepressants, and we knew that the tricyclics were associated with this risk of falling and a risk of therefore having a hip fracture. At the time in the late 1980s, early 1990s, this new class of drugs, the selective serotonin reuptake inhibitors, were launched, and the perception was that they were safer and they were less likely to lead to falling and therefore less likely to be associated with hip fractures. So this was the conventional wisdom in the 1990s. I've just basically explained that. Then in 1998, there was a big study, a large case control study published in The Lancet, which looked at this risk of fractures associated with both tricyclics and SSRIs. Now, what happened here was, for the tricyclics, the odds ratio for hip fracture was 1.5. Surprisingly, the odds ratio for fracture with SSRIs was 2.4. So this seemed to suggest that in fact the problem was greater for SSRIs than it was for tricyclics, and this was not expected. But this was in a big study where they adjusted for confounding factors, and these were the results.
Can I have a quick question? What's the comparison of these two drugs?
It's against no use.
No use.
Yeah, which we could maybe criticise the design of the study. I agree, but nonetheless, these were the results, and so the question for public health then became: did we get it wrong about the difference between tricyclics and SSRIs? But that's a really good point. So it was against no use. Yeah.
Another question. Did the study include insensitive user or include also prevalent user?
it would be potentially prevalent users because it's a case control study, so they would just be looking at, has this person recently been taking an antidepressant? Yeah. Yeah. So all good questions in terms of, I think, so this is 20 years ago now, and I suspect that these days we would design these studies quite differently anyway. Yeah, so they're good questions. So back to this question. The idea of choosing between SSRIs and tricyclics and an increased risk of hip fracture. The problem is, and if we think about the first cartoon slide I showed you with the two ladies and choosing between an SSRI and a tricyclic, the question is, are doctors prescribing the newer SSRIs to patients that they believe are quite frail because they want to try and avoid hip fractures in those patients? And so maybe the doctors were channeling those new treatments to the patients who were at higher risk. Does that make sense? I think in terms of clinical practice, I think that would be a good thing. But it means that it may be that this frailty is acting as a major confounder, which is then leading us to think there's a bigger problem with hip fractures for SSRIs than for tricyclics. So as epidemiologists, we can do the best we can to adjust for confounding, but we know there's often residual and it can be a big problem. So maybe this association or this bigger association for SSRIs is actually due to confounding. Because more frail patients are given the SSRIs. So the key issue is how we make the comparison. Who do we compare the treated group against? So I'm going to suggest that one solution is to not have a comparison group at all. And this is the premise or the lead-in to the idea of self-controlled studies.